Thank you everyone for joining the Alzheimer's Disease Research Center's Learn at Home series. My name is Abena and I'm the Outreach Program Coordinator at our center. And I would like to introduce Dr. Zhang. She's an assistant professor at NYU Rory Meyers College of Nursing, and her research focuses on leveraging mobile health and wearable devices for diabetes management. Dr. Zhang has received several NIH-funded awards, including NCATS and CTSI and NIDDK R01. She has also expanded her expertise in developing and testing innovative technology-based approaches to reduce care burden for older adults with comorbid diabetes and cognitive impairment. And with that being said, I will turn it over to Dr. Zhang, who will give the presentation today.
All right, thank you, Abner, for your nice introduction. And thank you everyone for having me. So today we're going to talk about the diabetes cognitive impairment. And then these two conditions have some connections, and one is risk factors, or they also have some challenges to manage both conditions together. So we'll talk about that in the next 1 hour. And so here's the overall overview of what we are going to talk about. As I said, the first one, we'll talk about the risk factor and then treatment goal, followed by management of the comorbid conditions. So I think maybe everyone of you are already familiar with this figure. Actually, last year, Lancet Commissions launched the report on the dementia prevention, intervention, and care. And in this report, they listed almost like 14 modifiable risk factors. And one of the risk factors you can see includes diabetes. Although these risk factors, you can see they can impact or associated with dementia, early life, middle life, or late life. But most of the risk factors occurs in the middle life. And one of the, as I said, risk factor is diabetes. So that is why we are really want to focus on the diabetes and the dementia. But as I said, in these conditions, diabetes is not only in the risk factor. Some of you probably already know that in the recent statistic report from the CDC, there are almost like 38 million people with diabetes in the United States. And among these people with diabetes, almost like 25 to 45 of them have mild cognitive impairment, and around 5 to 10% of the people have a comorbid condition of dementia. And also from the dementia side, you can see based on the recent statistic data, almost 7.2 million older adults with dementia. And again, among them, 37% have comorbid diabetes. So the two conditions really, co-collaborate together. And as we said, diabetes is a risk factor for the cognitive impairment. But on the other hand, when the people with cognitive impairment, they have some symptoms like memory loss, can also impact the diabetes management. Because we know the diabetes management is kind of like daily activity, needs the decisions for each task, like glucose monitoring, but co-occurring of the cognitive impairments really increase the challenge of diabetes. So this is overall, but we'll discuss each of them individually. The first one, as I said, diabetes is a risk factor for cognitive impairment. This study is actually published early in 2013, is a meta-analysis. So this meta-analysis analyzed 28 observational studies, and the overall risk ratio you can see here is 1.73, indicating that a 73% increased risk of all types of dementias in patients with a history of diabetes compared with non-people with diabetes. So this is a meta-analysis in 2013, and similarly, based on this systematic review, another review reviewed the most recent, like 10 years articles, and then they also reviewed 15 observational studies, again, showed the similar results, that the risk ratio is 1.59, and indicating that people with diabetes have a 59% increased risk of developing dementia compared with non-diabetes patients. So as you see, the two meta-analysis, the findings are very consistent. Another one is that is the study that we conducted. We used the HRS, the Health Retirement Study data, and to look at the association between diabetes and cognitive impairment. Interestingly, we look at the newly diagnosed diabetes, if they have some association with incidence of the cognitive impairment. And in this study, we look at the MCA, the outcome is MCA, mild cognitive impairment. So as you can see that the red color, this represents people with diabetes, and the line with the blue one is people without diabetes. As you can see that with time follow-up, and people with diabetes really have the higher incidence of the MCA compared to people without diabetes. And also when people have the MCA, people usually have the, incline to progress to dementia. And when the people has diabetes, the progression from the MCI to dementia progression significantly increased. So again, this is a review article, include 15 articles, reports, 12 studies. So the overall, you can see the unadjusted pooled odds ratio for progression of MCI to dementia in people with diabetes was 1.67. And as we said, the previous evidence discussed the diabetes as a risk factor for development of dementia, but also new evidence suggested that the age of the onset makes a difference. As you can see that this study look at the onset of the diabetes, like 5 years early or 10 years early, and then they look at the age onset of the diabetes if this associate with the incidence of dementia. And the interesting thing you can see here, the age of the onset really makes a difference with midlife, but not necessarily the late life diabetes onset increase the risk of dementia. And in this cohort study, is over 10,000 participants. The risk of dementia increased for every 5 years, decrease in age of diabetes onset until the age over 70 years at the onset. So as you can see that the early people with diabetes, the more risk people develop into dementia. And as I said, this is just the risk factors, and we examine all these risk factors. But what the potential mechanisms? And although there are different type of the hypotheses, we don't have the the very solid the mechanisms about the association between the two conditions. But some hypotheses include the first one is the insulin resistance, because some hypotheses indicate that insulin resistance can be associated with lower regional cerebral glucose metabolism, and this lower regional glucose metabolism will impact the function of the brain, and also the impaired peripheral insulin action leads to the hyperglycemia that include the high glucose, and this hyperglycemia may impact the dementia risk due to glucose neurotoxicity, vascular injury, or maybe accumulated some advanced glycations or some other factors. And another hypothesis highlights the role of macrovascular dysfunction, because we know diabetes usually have some macrovascular complications. And this macrovascular dysfunction can lead to the inflammation and also the immune responses. And these responses can cause the oxidative stress, increase the blood-brain circulations, and alter the blood flow regulation. So all these factors may impact the brain function and cause the dementia. But as I said, there's all the hypotheses, and some other researchers also hypothesize that some episode of hypoglycemia, because some patients, when people with diabetes, they may inject insulin or some other medications can cause hypoglycemia. And the hypoglycemia can occurs in the people, especially with long-term duration of the diabetes who use the insulin, and then this hypoglycemia can cause some type of the brain injury and cause the further, diabetes related dementia. And as I said, the mechanism is pretty complex right now. But what's the major components, what the major mechanisms, although it's not uncertain, but there's some hypotheses here, mainly related to like insulin resistance, like macrovascular damage or neuroinflammation or hypoglycemia-related brain damage. All these factors contribute to maybe the risk factor of the diabetes to the dementia or cognitive impairments. So if the diabetes is really the risk factors and how or better to treat diabetes. And currently, we know for the diabetes management, usually the diabetes management treatment goal is 7% for HbA1c. For majority of the people with diabetes, the treatment goal is 7%. Even though that is 7% goal, over 70% of the people did not reach this goal. But consider, we said, the impact of the hypoglycemia on the brain damage. So the American Diabetes Association actually generated the guideline for people with dementia or people with cognitive decline. And they indicate that the safe glucose control for people with cognitive decline would be the 8%. So if we screen the people with diabetes, then they also have certain type of the cognitive impairment. The treatment goal for HbA1c now set the 8%. And this way, the main purpose is to avoid the hypoglycemia, sorry. And another treatment goal for people with diabetes to prevent the dementia or cognitive impairment is early screening for cognitive impairment in older adults. Especially this is required for primary care providers if the people with diabetes and they're older, and this screening for early screening for cognitive impairment is required when the people visit the primary care providers or endocrinologist. Okay, as I said, if we know diabetes associated with dementia or cognitive impairment, but if we need a very tight diabetes treatment. So the answer here, you can say, is come from a systematic review published in 2018. And then this, again, a review focused on the meta-analysis of pharmacological treatment of diabetes and also how this treatment associated with cognitive impairment. And this study includes 37 studies, and they investigate the anti-diabetic treatment compared with no treatment. Overall, as you can see here, this is overall risk ratio is 1.01, almost like if we look at the overall treatment, looks like the treatment on the diabetes has no impact on the cognitive impairment. This is a very interesting result. But if we look at the study, we can see some differential effect across the drug classes. And if you look at this right color highlighted part, this type of the drugs is mainly related to anti-diabetic or anti-hyperglycemic treatment, which related to like insulin or sulfonylurea. These two type of the treatments mainly focus on lower glucose levels. But when you look at the impact of this treatment, looks like the impact on the cognitive impairment or the negative part. Means that when the people using those type of the treatment can increase the incidence or progressive cognitive impairment. Instead, if you look at the other types of the treatment, like metformin and others, those treatment focus on the improving insulin sensitivity. So it's not focused on the lower glucose level, but focusing on the improving insulin sensitivity. But when you look at the treatment effect on the cognitive impairment, you can see that the impact actually is kind of like a protective impact rather than the negative impact. Okay, so when we look at those effects, we have different type of the drugs, and their impact, the treatment effect on the glucose also has certain type of impact on the cognitive impairment, indicating that maybe different treatment mechanism has different impact on cognitive impairment. And one of the potential explanation is the severe hypoglycemic episode may be associated with increased likelihood of dementia. So as I said, this is really the current, some traditional treatment of the diabetes. And some of you might familiar with some new treatment for diabetes, include like GLP-1 receptor agonists, and also some SGLT2 treatment. And these two new treatment, some early treatment also for some early trials trying to look at if the new treatment of the diabetes can impact the cognitive impairment. But these new clinical trials are ongoing, and we have no further result. But some preliminary outcome indicate like GLP-1 has certain type of protection of cognitive decline. Okay. And as I said, if the tight treatment sometimes cause the cognitive impairment, if it's a protective or negative impact, there is not uncertain. So if the people have the comorbid conditions of diabetes and cognitive impairment, what we need to do, and one more thing is that because it can cause the challenges of managing the comorbid conditions. And as a potential reason, I mentioned that like when the people have the cognitive impairment, they probably can have some changes in the memory or thinking, which can impact their daily decision for diabetes management. And because of this reason, and the majority of the patients have both conditions need a certain type of the caregiver support. Okay. But even we have the caregiver support for the people with two conditions, the care burden is very high related to the management of both conditions. And there are several related factors. You can see at least the several factors here, and some factors related to maybe caregiver have no insufficient knowledge or the skills for the shared responsibility. So for example, if the people have diabetes and with the comorbid condition cognitive impairments, and people need to know like daily medication adherence, or maybe some people need daily glucose monitoring, but the caregiver has no knowledge of the medications, how to better support the adherence. And also some caregivers may have no skills of help patients to monitor their glucose. So this insufficient knowledge and skills for shared responsibility really increased the care burden related to both conditions care. And sometimes we know, especially at the late stage of the people with dementia, and they kind of like show certain type of care resistance or uncooperative behaviors, especially like glucose monitoring. Some people with dementia, they don't want to or reluctant to do the glucose monitor. That increase the other layer of management of both conditions. And third one is difficulty in effective communication. We know, especially for a certain type of dementia, at the late stage, and then they probably show the difficulties in the communication. So all of this causes the challenges and the difficulty for caregiver to better care for both conditions. To resolve these issues, we conducted a systematic literature review and trying to see the non-pharmacological intervention for people with both cognitive impairments and diabetes. The reason why we do the non-pharmacological intervention review, because we know for dementia right now, we have no solid pharmacological treatment to treat dementia. And for the diabetes, although we have certain type of the drug to treat glucose, but for diabetes management, most of the type needs the patient's or family involvement for daily care. So that is why we conducted the non-pharmacological intervention for people with both conditions. So in this review, we include a total of 14 articles. And these 14 articles include 7 clinical trials and 5 pilot studies and 2 mixed method study. And the intervention types including like diabetes education, Tai Chi, or some diet, exercise, lifestyle intervention, or cognitive training, or using the technology. So you can see that all these intervention type mainly focus on the patients, but not focus on the caregiver. This is very interesting because as I said, for people with cognitive impairments, especially for dementia, and their care really needs the help of caregiver, but none of these involved studies include the caregiver in the intervention. And the intervention effects shows that 3 studies improved their glucose outcomes like A1C, and 4 studies showed improved the cognitive function, and 2 studies showed improved the dietary intake, and 2 studies improved the self-efficacy of managing the disease. So from this literature review, as we can see that for these non-pharmacological interventions, as I said, none of them focus on both patients and the caregiver intervention, only focus on the patients. Although the study focus, the outcomes look at the glucose or cognitive function, but not every study focus on both outcomes. And because of those such of the gaps, and we conducted a study trying to using certain type of the technology to help people manage the conditions. And one of the advanced technology is called the continuous glucose monitoring. So the continuous glucose monitoring, some of you probably are familiar with, is actually a hair-sized sensor. It's very tiny, and this hair-sized sensor, the outside looks like a button can attach to the skin of the upper arms. And when the people wear these sensors, it compared with a smartphone app. So when the people open this smartphone app, people can see the glucose anytime, anywhere. So this is different from the traditional finger stick glucose monitor, because we know for the traditional finger stick glucose, we can only say 1 glucose each time or each day. It can miss a lot of informations of glucose levels. But for the continuous glucose monitoring, as you can see that it can offer the glucose every 5 to 15 minutes. So 1 glucose every 5 to 15 minutes. It can show the pattern of the glucose. And in this figure, as you can see, the green area here is normal glucose. If the glucose above the normal, then in the yellow area, indicate the people have the higher glucose. But in the right area, indicate people have the low glucose period of time. So using the continuous glucose monitoring, it not only show people when they have the hyper or hypoglycemia, but can also show that their duration of the hypoglycemia. Okay. And because of these advantages, as you can see, all this glucose monitoring is automatically, which has the potential to reduce care burden for the caregiver perform glucose monitoring for patients or remind the patients to do this glucose monitoring. Okay, and this is one advantages for people use this type of the technology. And another advantages is that this CGM data or glucose data has a function of sharing the real-time glucose value with care patients, with care partners. So that means patients, care partners can see their glucose at the same time. And care partner don't need to stay with the patients. They just can see the glucose values from their own glucose levels. So in this way, because of the two main functions, it probably has a potential to reduce care burden. So this is how we conducted this study. As you can see that when the people, like patients wear this CGM and on their arm, and they can see their glucose on the patient's phone. And at the same time, these glucose values can shared with caregivers or care partners. So caregivers can also see their glucose on their side. And at the same time, patients' data can also share their data with our researchers. So kind of like three parties can see patients' glucose levels at the same time and anywhere. In this way, we can achieve to the goal of the bidirectional communication among patients, caregiver, and also the researchers or even the clinicians, which can impact the patient outcomes and also the most important to reduce the caregiver burden. Okay. And this is how we conducted the study. As I said, this is a pilot study, and we enrolled around 10 paired patients, caregivers, and we have some preliminary results and showed the impact of how we use this type of technology impact the patient's health outcomes, especially for their glucose management. As you can see, this is a figure shows at early beginning when a patient wear a CGM. And this figure shows the 12 a.m. to 12 a.m. glucose levels. Okay, as I said, CGM can provide consistent glucose values and also the patterns of glucose. So this is 12 a.m. to 12 a.m. patterns. And here you can see we set up the goal for patients if their glucose levels, normal level or normal range is between 70 to 180. But for these patients, you can see almost 24 hours, their glucose level is high. Although for the people with dementia, we can set up a little bit high goals, like 200, 225. But no matter for what, as you can see that these patients, at the very early beginning, their glucose is very high, almost 24 hours. We are very impressed by how per glucose control for these patients. And then we started to ask patients to wear this technology and gave some certain type of the guidance. The first guidance we gave them is to ask these patients and the caregiver to do a simple food log to monitor their food intake each day for each meal. And then to observe how their meal impact their glucose changes. Okay. And we also asked them to log their medication intake and also their physical activity. All these activity assisted by the caregivers. And at the same time, we identified that these patients usually eat out and not cook the food at home. And sometimes these patients has low adherence to the medication. So we provide some basic suggestions to these patients, ask them to observe glucose change for next 2 or 3 days. And we tell them that if the glucose has no any of the changes in the next 2 or 3 days, we recommend them to see their endocrinologist or PCPs. But the good news is that after 7 days, you can see these patients stay at home, not eat out, and the caregivers started to help them to prepare the low-carb foods, and they do certain type of physical activity and adheres to the medication. And as you can see that this patient after 7 days, the glucose for certain time point, like after lunch or dinner, glucose still high, but it's remained the shorter period of time. And after or between the meal times, as you can see, most of time, the glucose remains normal. So this is very impressive, just using the technology and change their lifestyles with assistance of their caregivers, and then they can achieve the better control of their glucose. And one of the important thing of the caregiver involvement is that because usually for the traditional intervention, we have to require the caregiver to stay with the patients together. But for this study, because of the sharing the glucose levels with caregiver using the phone, so the patient caregiver not necessary to live together. They can caregiver can help patients through the phone and or remotely, so they don't have to stay together to get the support. Okay. And we also received a certain type of the qualitative result. And the first impressive qualitative result is that the patients impressed that it can increase the effective family communication and strengthen the family bonds. And some participants expressed that at the beginning or in their previous communications, the caregiver wants to help the patients, but not quite sure how to better help them. The main thing they said would just provide a certain type of the reminding, like you need to eat, light food. You need to go out for exercise. You need to take your medication. But patients sometimes ignore that, or patients sometimes kind of like just don't listen to them, show certain type of the resistance. But after using this certain type of technology, patients said they, because they can share their glucose with the care partner, and the care partner can check their glucose time to time and ask why your glucose high, what you eat, something like that. And then they increase the better communication and more effective communication for caregivers and care recipients. And another qualitative result showing that the CGM is easy for glucose monitoring with no pain. Because some patients said initially when they're using the traditional glucose monitor like the finger stick, it's complex procedure with the pain, and people sometimes reluctant to do that. But with this CGM, they can see the automatic glucose values, and they don't need to check the finger stick each time. They just open the phone and see the glucose and try to identify the potential reasons why their glucose is high or low. So this is very helpful for them to manage their comorbid conditions. As I said, this is really the preliminary data analysis we conducted, but we'll provide certain more type of the results at next week GSA conference. If you are going to go to this the GSA conference, and you can stop by our studies and to learn more details of this information. So as I said, this today I just focused on several topics. Then the first one, we know that diabetes is a risk factor, but it shows really like it's a midlife risk factor. And if the people have diabetes at late life, properly is not associated with dementia. As this is one type of the things sometimes people will misunderstand. And also in our presentations, when we talk about the diabetes, actually it's mainly related to type 2 diabetes, because type 1 diabetes is different story, although type 1 also related to dementia, but the mechanisms is totally different from the type 2 diabetes. And the second thing about the control of the diabetes, as I said, based on the mechanisms, looks like maybe we need to better control diabetes, to tightly control that. But based on the systematic literature review, it shows that the tight control of diabetes may not prevent cognitive impairment. So we need to continue have more evidence to show how to better control diabetes can slow or prevention of cognitive impairment. Okay. And the third one is that maybe using the advanced technology has a potential to reduce care burden for both conditions. But this is really in the early stage. In our study or in the other studies, both are very in the early stage, and we can see how the technology can help, shift the treatment or shift the management of the both conditions. Okay, so I leave the more time for our discussion.